Hello. So I'm now going to present this critical appraisal. You'll need to follow the slides as I've put on YouTube as a movie. Unfortunately, I've not been able to film both, so you'll have to see me during this time or not look at the slides. So slide 1, this paper is entitled Adelaide Stroke Incidence Study, Declining Stroke Rates but Many Preventable Cardioembolic Strokes. It's published in March 12, 2013 in a reputable journal called Stroke. James Layden is the lead author of this multi-author paper. Slide 2. So this introduction given in the paper is that stroke is a major health challenge, and the major questions are what is the incidence in Adelaide of stroke and subtypes, and is the stroke incidence declining or increasing with ageing populations? The introduction was brief but appropriate. Slide 3. The methodology of this study was that of a prospective observational study. It was an urban incidence study covering 12 months from the 15th of July 2009 to the 15th of July 2010. It was found to have 148,000 residents in the catchment area and mostly a higher elderly population compared to other regions in metropolitan Adelaide. Stroke definition was from WHO, and they used a TOAST classification in regards to large artery, small vessel disease, etc. Ascertainment was by a stroke neurologist and 2 nurses, and they attempted to catch all patients who'd had a stroke or people who had a stroke in that area using emergency department, nursing homes, outpatients, general practitioners, physicians, radiology requests, and death registry. Patients were interviewed or next of kin interviewed, and medical records were followed. Overall, the methodology and the study design appear to be appropriate and comprehensive. Slide 4, data collection and statistics. It was stated that a purpose-built database was used, but more information in regards to this would have been helpful. Incidence rates were determined for first ever stroke and calculated per 100,000 people per year. Confidence intervals were calculated from Poisson distribution and reported with 95% confidence intervals. Rates were standardized to the world population. Critique of this particular section was that it were simple statistics. They appeared appropriate and were consistent with other studies. Slide 5. This was showing the study design and was very useful. Overall, it demonstrated that case review were of 1,401 patients seen by research staff, so large numbers, and eventually they were confirmed using a diagnostic panel with only 11 cases rejected, and overall 318 events with 304 patients. The next slide, 6, is Table 2, age and sex specific stroke attack rates. Overall, the incidence stroke rate in this study was 215 per 100,000 person years. There appeared to be a marked difference between age groups, and as you can see in this slide, in the red boxed areas, there were found to be 60 in people less than 65 years of age, which increased significantly to 2,251 when aged greater than 85. There appeared to be little difference between sexes. In slide 7, the table 3, which relates to first ever lifetime stroke with subtype. Overall, 74.8% were first ever strokes. Crude incidence rate was 161 per 100,000 people. Adjusted, the world population was 76 per 100,000. You can see how these are attained looking at the various subtypes. And males had a higher incidence to females. Slide 8, in regards to results, is very interesting information in regards to the stroke type. 17 strokes had no imaging, and therefore the stroke type was unable to be determined. Essentially, the cardioembolic stroke type was the largest with 42%, and this was found to increase significantly with increasing age, as you can see by the light blue colour versus each age group. Case fatality of all strokes at 28 days was 19%, and as seen before in other studies, bleeding was much higher incidence of fatality at 35% versus 16% for ischemic stroke. Other results, which I don't have sufficient time to go through in detail, demonstrated that hypertension, hypercholesterolemia was significantly represented as risk factors. Smoking, only 13%. Only 11% of people described a previous TAA. This is somewhat low, and there's very little information on this given in the paper. In regards to cardioembolic strokes, of 81 out of 109 were found to be due to atrial fibrillation being reported by the person, and 70% were diagnosed prior to the stroke. When looking into reasons for whether the patients were anticoagulated or not, 85% were considered to be inadequately treated with previously known atrial fibrillation that should have probably been anticoagulated. This is one of the major findings of this study and is very important and well described. So in regards to discussion and critique, the discussion is well laid out with only 2 or 3 major points with limitation of space, and it was said that despite aging, crude stroke incidences were not found to have increased significantly, and as you can see in this slide, it certainly remains around the similar incidence rate compared to Perth and Melbourne studies. It was considered that advances in primary prevention and reduced smoking rates may have attributed to this. What is most important is cardioembolic burden, probably being due to older patients being, and also that it was clear that patients were not anticoagulated, perhaps overcautiously. 1/3, in fact, of cardioembolic could have been strokes could have been prevented if treatment guidelines had been adhered to. Limitations of the study related to some patients may have been missed. 9% were found retrospectively and 5% were not imaged. Overall, my opinion of this paper is that it was well presented, tables were well presented, and overall it was good, and I think should have been published, and it was certainly worthwhile in regards to the information presented. Thank you very much. I think on timing I've taken 8 minutes and 30 seconds, so I've gone over the 8 minutes, so you need to do better than me. Hopefully this is an example of what you will be presenting next week on Wednesday and Friday. Thanks for your time. Bye.